Wonderful. Thank you all for being here. My name is Pete Clardy. I'll have a chance to talk with you a little bit later about clinical AI and the work that we do at Google to sort of reimagine what the future of clinical care might look like. But now I'm really honored to have a chance to reflect on a different part of my background, which is as a medical educator. And over the course of my career, I've spent a lot of time teaching medical students, trainees, and colleagues. And so I'm really honored and delighted to be asked to moderate a panel on health professions education and the future of where we're going with medical education in the digital and the AI era. And I think just by way of reflection, health is an incredibly powerful use case for the societal benefit of AI. Similarly, education is an incredibly powerful exemplar of what AI could do to empower people at scale across the world. So that intersection of health and education, health professions education, I think is sort of a magical opportunity, and I lead at Google our efforts in health professions education. So with that, as a little bit of a prelude, I'm really honored to welcome my collaborators and discussants to the stage. And I wanted to maybe outline a little bit of the plan for the next 40 minutes or so, organized around first the academic core and thinking about the implications of these new tools and technology for those currently in training or those entering the profession. And then we'll turn to those who are already practicing and the implications for new tools on care delivery. And then in the third section, really sort of looking forward to where we may be heading in medical education. So to open our discussion, I'm honored to begin with Dr. Narendra Kumar Are, a new friend who I met yesterday and who I think shares a passion for medical education in his role as the Director of Medical Education for the government of Telangana. And so Dr. Narendra, from your standpoint as a Director of Medical Education, the challenge of scaling a modern curriculum across dozens of colleges is a huge administrative challenge. And so as we look forward, maybe over the next 5 to 10 years, as you start your plan to systematically integrate digital health and AI into formal medical education, how do you do that without overloading a group of students that are already burdened by so much to learn?
Dr. Clardy Garu, my co-panelists, Dr. Chinnababu Garu, the man behind these workshops, and all my dear delegates, a very warm and good morning to all of you. We have at present a three-tier system, health system is running in Telangana: primary health, secondary health, and tertiary health. Primary health includes the PHCs and UHCs. The secondary health is district hospitals, and tertiary health, the government general hospitals attached to the teaching medical colleges. So we have 35 medical colleges, 47 government hospitals, and 21,258 inpatient beds. That is the health structure of the Telangana. So regarding the integration of digital health and artificial intelligence, the government is aware and awake. We are integrating whatever the developments which are happening into the medical system. We have to make our students the future ready. Our aim is they are not only clinically competent, they should be digitally competent also to face the present world. So the problems which can crop up is taxing the already existing curriculum, the faculty readiness for this digital transformation, and also the infrastructure deficiencies among various institutions. All may not cope up with it. To overcome, we could able to find out some solutions, and now I can say we are active, we are awake, we are actively investing towards the digitalization, and we are introducing digital health and artificial intelligence in the curriculum and in the clinical practice. And in one word, I can say we are on the board. The methods what we have implemented is the first and foremost the foundation course. In the foundation course in the MBBS itself, we teach them the basics of artificial intelligence, database, cyber privacy. So the foundation course is the first step for introduction in the curriculum. And what we are taking care is this integration should not tax the existing curriculum. Within the existing curriculum, we are taking a space and a sustained program to make them acquainted throughout their career, pre-clinical, clinical, and internship. They should be digitally competent. The second thing what we have integrated the digital health and AI in the already existing subjects like radiology, pathology. We have in the process of procuring for 3 medical colleges this artificial intelligence machinery for pathology, where it can read 16 slides at a time and give us a report on what are the abnormal, what are the normal slides. We have already have a tie-up with the digital platforms for the radiology. We heard a wonderful lecture from Dr. Nagarjuna. The same QI we are also negotiating. We have a huge number of X-rays starting from primary health centers to teaching hospitals. So the first thing that what the AI will do is the normal X-rays are segregated. Only the X-rays which needs to be examined and expert opinion is needed will be isolated. So that will reduce the human interference for and spending time for the normal X-rays. That's the way already existing subjects we are introducing the AI modules. The third thing is the skill labs. Wherever there is a deficiency, like cadaver deficiency is there, we have ordered for, in the process of procuring virtual anatomy tables for 3 medical colleges. This will replace the, wherever there is a deficiency of cadavers. So they are all interactive boards they have, and the students can have a real-time touch with the virtual anatomy tables. Virtual patients and also augmented reality we are going to procure for the 9 old medical colleges which are there out of the 35. So skill development, and we have a wonderful skill labs in Osmania Medical College, Gandhi Medical College, and Kakatiya Medical College. These 3 colleges have a wonderful skill labs where the students can get trained on virtual models so that they can learn without compromising the patient's safety. The AI tools and digital health is going to help them in integration in that aspect. The other thing is the faculty training of the trainers. We have already identified the teachers among our faculty, and we have a tie-up with the triple IT to train the teachers in the digital health modules, and once they get trained, they come back and teach the other. This is a module of TOT, training the teachers. And another way we can do is, once the student goes into the clinical postings, the HMIS system is already existing. We call it as EHMIS, Electronic Health Management System, which is already existing, which is within the purview. It is mandatory put by the National Medical Commission, which is the authority under which all our medical colleges will work. So the system works like this. When a patient walks, they have to get registered with ABHA, Ayushman Bharat Health account. Once he generated account, a OP slip will be generated. From then on, whatever movement he moves will have to be registered, will have to be documented, and this document will be monitored by the NMC. So all medical colleges, to get recognition, this HMIS system should be implemented. And what we do is, during the clinical postings, we make our students to help the data entry people. So they can have an acquaintance with the system. They can have an acquaintance with the health management informatics system. So this ABHA generation, Aadhaar-based attendance for the faculty, and the whatever the KPIs, key performance indicators like OP, IP, surgeries, deliveries, everything has to be digitalized, entered, and it will be monitored by the NMC for the recognition of the medical. So this way we have already integrated, and students are getting exposure to it. We have an interdepartmental collaboration with Triple IT. So they come, they teach our faculty and students, and our faculty will go there. So interdepartment collaboration is the one thing that we have introduced for the purpose of integration of the digital health. The other thing is, we have a module for assessing their, we are now planning for assessing their competency in digital health by conducting OSCEs, object to scoring systems, and we encourage the students to participate. Hyderabad, as you know, is a happening city. There are many AI conferences. In this month itself, I have seen 3 conferences on AI. So we encourage the students to attend, and in this hall and in this conference, we have sponsored 100 students to attend this conference. This is one way to encourage the active participation of the students to enter into this, getting a technology edge and also a technology taste. So to say that we are already on board and we are moving forward, and we are awake, and we are actively investing in integration and digitalization of the health structure.
This is an amazing overview, and again, the ability to kind of link together baseline course to ensure safe use, the incorporation of pragmatic AI in areas where it's already being used, like radiology and pathology, to focus attention on high-value cases, use in simulation, use in augmented reality, use with OSCEs, tools for educators, tools for tracking progress and understanding competencies. It's remarkable, and I want to maybe shift to Dr. Ushrani Thota. Dr. Rani, you are a leader, ADME superintendent at Nagar Kunal Medical College and Hospital, and I'm wondering, as an academic administrator, hospital leader in a growing regional center, sort of what are the real world operational realities for the trainees who are coming into your institution? What fundamental computational fluencies, algorithmic bias or data privacy issues should be standard for those students before they step onto the wards?
Yeah, very good morning to all. Thank you, Dr. Peter, for a very pertinent question. And our DMEs are already explained in detail what are the digital technological competencies which we are testing in our medical colleges. And the main aim is the students who are passing out from our medical colleges, when they come to work with Dr. Chinnababu Garu or any other specialists who are present here, they should not feel lost. So they should learn all the competencies which are prescribed by National Medical Council, like professionalism, and also medical knowledge, procedure skills, and communication skills. In addition, they should also achieve proficiency in AI literacy. So how do we test? So at least 4 fundamental fluencies are necessary for every undergraduate or postgraduate. One is the electronic health record. As we are seeing in our clinical environments, they are increasingly being incorporating electronic health records, digital diagnostics, telemedicine. So the competency of maintenance of electronic health record should be one core competency. The others being identification of bias in AI generated outputs. A third, I would say, would be cyber hygiene. And also fourth is telemedicine skills. So coming to maintenance of electronic health records, as our DME sir has already told, so EHIM is in place in all government hospitals. So our students, once they pass out the final MBBS and come to the clinical rotations, they should be able to understand how to navigate the electronic health records, how to accurately enter the patient data, and also how to maintain privacy, data privacy and patient confidentiality. So just by removing the name, we cannot hide the patient identity. We should also know by clinical profile, they may be identifiable. So similarly, they should be able to understand how to navigate the dashboards, how to interpret the performance indicators, and sometimes graphic representations can be misleading. We often see some of the sponsored clinical trials, even if the statistical significance is very minute, they represent in such a way that the graphs look too huge, and unless you critically analyze, you won't know that is a misleading visual representation. So students should be able to analyze in such a critical way. And coming to the second competency, that is understanding the AI outputs. So we all know AI outputs depend upon the historical data and also what kind of references are used. So you should know how to give the proper prompts and also the limitations of AI generated outputs. So suppose if there is a demographic bias or if there is a hallucination in the AI generated output, a student should be able to critically analyze and find out. And ultimately, we know that clinical observation and judgment is paramount. And if a mechanical output is showing some conflicting result, student should not blindly trust it. Rather, he should challenge it with his clinical judgment and observation. Coming to the cyber hygiene, how we are well versed with infection control to maintain sterility in our surgical theaters. Similarly, cyber security is a very important aspect we all should learn, because any cyber attack on hospital software will not only disrupt the workflow, but also it will breach the patient confidentiality. So we should know what are the phishing attempts, how to maintain the password security, etc. And coming to the last part, that is telemedicine. We all, after COVID, we know there are so many virtual consultations, and specifically in remote areas like tribal villages, even peripheral medical colleges, sometimes we do not have a super specialist. So we depend upon digital consultations. Even in our center, CT scans are read by telemedicine through radiologists who are sitting in the city. So all graduates and all medical students must know how to do digital consultation, how to maintain informed consent process, how to do the informed consent process on digital platforms, how to maintain patient privacy on digital platforms, etc. So these are some of the core competencies which we need to test, and our aim should be to produce digitally responsible clinicians who can work efficiently in an AI-enabled environment, but at the same time, we must preserve our clinical judgment, ethical considerations, and also we must preserve the patient trust on us. Thank you.
Thank you. A remarkable answer. And I want to emphasize one thing that I think you put so beautifully, like you would never go into an operating theater without all of the protections required to ensure safety of the patient. And similarly, cybersecurity represents the same sort of fundamental protection required for good patient care. So all good analogies get borrowed. I may borrow that one because I think it really gets to the heart of the issue. I want to shift gears slightly to those who have finished training, those who are completed with training, and some of the challenges that we see in those entering or the need to upskill a massive cohort of senior physicians and faculty who, like me, trained in a more analog era. So Dr. Sunitha, in your role, a DME superintendent at GGH Medak, I'd be interested in your reflections on the fact that medical education doesn't end at graduation. We can't wait for the next generation to mature. So how do you think about structures and mechanisms, whether that's CME or mentorship programs that can help elevate the readiness of those currently in practice?
Good morning, ladies and gentlemen. So there is something called a district residency program that's happening in Telangana government, wherein it's not only Telangana, of course, in many other states also, wherein people, postgraduates from city, from urban areas are posted to peripheral centers. Like we get students from Mallareti College to Medak. So when these DRP students come, it is but natural for us to take the teaching aspect also into consideration. In addition to teaching them skills of the surgeries and all that, the teaching aspect also comes into picture. So we don't allow usually the students to directly touch the patients, do the surgeries and all that. So even before they do that, we need to go for a simulation-based training for these people. Simulation-based, it's not just for surgical procedures, something like laparoscopy and all that, laparoscopy, hysteroscopy, but we need to go for simulation of emergency drills, emergency procedures, ECG reading, the ICU protocols, monitoring and all that. See what happens, here they learn the aspects of it. N number of times they can learn till they become expert in that. Then we can allow them to go on to the patients so that the risk, of course, will come down and they also will be in a confident state to deal with situations. So one is that. Second aspect is when we are teaching, even the curriculum, the teaching aspects is differing now because of AI and all that. Initially, it was just taking a lecture, giving assignments, and conducting an exam now and then for them. But now this has been changed. We are going for flipped classroom models, and then the teaching models, the assessment models also is being changed now. So we are going for the structured OSCEs when we are assessing them. We are problem-based learning methods, and then virtual cases we can use. So we are making use of all these things, students, medical students basically. And since this is the learning is an ongoing process, like right from the foundational preclinical courses to the clinical aspect and to the PG level, as well as research and fellowship also, it should be in a stepwise manner. You cannot dump all the things on one day. Overnight, nobody is going to learn anything. Why? Because if we stage it right from day one till the ending, the comprehension is better, the memory retention is better, and the depth of the things that we are going to teach them is going to increase day by day. It is like that. So we have changed the curriculum, the assessment methods and all that. And like I told you, simulation plays a huge role in teaching the medical students.
Amazing, thank you.
Thank you.
One thing that I've observed, and I'd be interested, and we can maybe talk in discussion, is that we've seen in the US a somewhat inversion of what has historically been a top-down approach to education. And one of the things that I'm interested in is that we're often seeing students as the most advanced AI practitioners as it relates to teaching and learning. I'm interested from the group whether there have been opportunities for students to be the teacher. My belief is that that is something that unlocks a different sort of collaboration, and maybe wondering if you've seen examples where students bring new ideas to an organization that help inform how faculty may practice.
See, AI learning is always interactive. It's not that rote learning, that memorization, that classical lectures, giving lectures and all that. That's what we talk about this flipped class. See, we tell them, you read and come about a topic. And then question based. We are basically asking questions and they are going to answer. And then they can definitely give their inputs and everything, especially when we are discussing virtual patients or real life case scenarios and all that. And that is not only that Socratic method of learning also, this is also basically a question based. The inquisitiveness, the creative ability of the students, they all come into fore in these teaching models actually. So definitely we encourage all these things, and we give projects which can be AI based, which can be anything, like certain common things that are present in the society. We can give a small project to a group of students, and the team building activity also will be there. That communication skills, team building, they come into fore, and they can take up all these things, and this is sort of interaction. So they keep telling us few things and then we keep asking questions. It is like that. Rather than giving them long lectures. See, that modality of teaching is gone now, actually.
I think that's
more like interaction.
Yeah, I think that the sort of flipped classroom, more interaction, moving away from large format lectures is not directly an AI, but it is really a reflection of sort of new modern teaching methods, which are fantastic to see. The other place where I think simulation is particularly useful, and you've already described it, is in these high acuity, low occurrence events. You know, that it's impossible to sort of give training when they're actually happening in real time, but they are fortunately rare events, and so training for those so-called halo, high acuity, low occurrence events is a fantastic use case.
In this assessment, we use the Miller pyramid, like CBME based assessment and all. The same Miller pyramid we can use for assessment of AI also, wherein the DUS part of it, that is the actual part of it which doctors do in the examination. So the DUS part of it, we can make it a simulation based. Like we can give one competency, they can do it by simulation based, which is already existing in our teaching methodology in medical colleges. Supposing there's a property insertion, we tell them the core competencies. We have chosen certain core competencies, the National Medical Council, and a medical student should know these 13 core competencies the day he becomes a resident, he or she becomes a resident. So that core competencies, we can test them the simulation based, which is already existing in the medical colleges right now. The Miller pyramid, actually.
Yeah, the Miller pyramid, absolutely. So turning, Dr. Kola, you and I are similar in our backgrounds in terms of our areas of focus. You direct the medical services here at Yashoda Hospital. And so from the perspective of a premium private healthcare organization, you really sit at the epicenter of where technology meets consumer care. And so from that perspective, do you see gaps in young physicians in terms of the skills that are required to kind of enter a modern tech-forward hospital ecosystem? And can you think of ways that those can be addressed?
Yeah, good morning, and thank you, Peter. Recently been elevated to this Director of Medical Services from the role which you currently on. And see, all of you who have been here from different medical schools or the different graduates, medicine or an MBBS seat was all about managing a patient individually. Look at probably the diagnosis, management, treatment in the form of medical management or a surgical management. This is what was the pattern when still in recent times, maybe a couple of decades back. The things which we realized of late in the last 2 decades were the communication skills were never been a part of the medical educational training. And when you come to a hospital of this stature, with the epicenter, with so many well-informed people who will ask you hundreds of questions, and you need time to actually communicate. This was a change which we have seen happened over the last 2 decades, that the communication was an integral part. Research was done as a part of dissertation and not been very serious component, whereas we see we have been different from West. So that has been taken over in the last 2 decades. In recent times, we realized medicine is not just about managing an individual patient, but it is a management of a healthcare system also. And where do we stand there? See, if you ask me, I'm very happy today to actually listen to the system from the government of Telangana and DMEs and all the principals of the different medical colleges talking about these already are on board, and they are already started practicing. But if you ask me what is the gap we are seeing here, the first thing is data and digital literacy and AI literacy, illiteracy, which we are talking about. These three components, data, digital literacy, has been not a component of my postgraduates or graduates who have been joining me to be a part of my institution. Both have been not. It's been like they are managing individual patients with a diagnosis, treatment and surgical skills, and as ma'am said, there were some probably acute care skills like a CPR skills, BLS, ACLS, some anesthesia colleagues have their own skills, emergency colleagues and ICU colleagues have their own skills. But other than that, these kind of interpretations have been not there. I am happy and glad. Coming back to the corporate sectors, which most of the corporates right now or the epicenters right now are managed by the electronic medical records. And the electronic medical records has never been exposed to the graduates or postgraduates earlier. So there was a gap. We used to run dashboards in many of our hospitals, where these dashboards are driven by data and quality metrics. This quality metrics was never been monitored. You talk about a standardized mortality rate, infection rate, complication rate, and many things, which has been an important integral component of any of these quaternary care centers. And you have been questioned why your SMR is high, why your infection rates are high, why your complication rates are high over and above the benchmarks. And these kind of integration happens with an EMR will be one step ahead of the current regular requirements. Lastly, the clinical decision support system. See, we all think that we have seen some of the beautiful presentations and elaboration from our Nagarjuna sir's presentation in pulmonology department, and we have seen radiology department has put something, and pathology, and we have already learned from different experts here that AI is able to help us, okay? But my component will be, are we now in a state of understanding the biases and limitations of AI? My graduates, my postgraduates cannot take carried away by these kind of maybe a conferences or as the discussions. As Dr. Nagarjuna in his last few statements made a point that he has to train that AI model repeatedly by giving feedbacks. There was a repeated resets happen. And then now the accuracy has gone up, the sensitivity, specificity has gone up. Otherwise, if it picks up more and more false nodules, you'll end up in doing more and more CT scans, and you'll end up in probably doing maybe more biopsies in a low risk grades. So these are all collateral things which can happen. So my postgraduates or graduates who come to me should also have a depth analysis of what are the limitations, what are the biases in this AI algorithms or AI literacy need to be understood to them, at least at a basic level before we go there. I will end my summary will be something like that. Artificial intelligence is never going to replace any natural intelligence or human intelligence. But if a doctor who doesn't know AI will be replaced by a doctor who knows AI, that's for sure. There's no question of that. You cannot actually today practice medicine without knowing a computers or without knowing a PPT or an Excel sheet or to review a literature somewhere. In the similar way, you have to be an integral part of it. It started augmenting. It will probably take a bigger roles. So we need to have this both data and digital literacy and basics of AI probably standards, which already been integral part of some of the medical colleges, should be a part of our educational system. When they come to me, I will expect them to know those basics. At this point of time, we are running something dynamic case sheets which are run through a EMR and parallelly run through a AI. Okay, that AI every hour tells me, look, your patient's vitals were like this, your doctor is treating like this. According to the world review of literature, the AI gives me a prompt that probably these differentials and management should be considered. Believe me, out of 20 prompts, we are able to only pick up 1 or 2 prompts which are critical. The rest all were over prompting or probably less of sensitivity. So we're again cleaning them, as we say, the hallucination or all that parts. So this will be a journey which we all have to go through, and this will be a revolution, I think, in the part of a medical professionals we will go through.
Amazing, thank you. And one thought there, yes. The moving a clinician, learner, or experienced clinician away from kind of managing a single patient and collecting data to sort of managing a population and organizing and orchestrating data, I think is also part of what you're describing here.
Yeah, see, the country where we are, there is a, even in spite of so many expansion of medical colleges, the graduates, nursing, skilled population, all of you know we are short of it. As of today, I have sort of 50% of DMOs, 60% of nursing staff, and we all know how many skilled manpower is still short in this country for a premier institution like this. So there's no question that we are going to face this. And as a critical care clinicians, we may not find these experts everywhere. So this AI integration, for example, my central dashboard can be connected to my system, and that central dashboard will give a predictive model which of my patient is showing a trend towards maybe an event in the next few hours. So I should be more attentive. I alert my consultant in that area. Look, these are the patients, patient number 8, 10, 15, these are the patients where the trend doesn't look like great and there is an alert coming, so keep a watch what is happening. So the similar way, a digital health where I can actually look back at the data from another of my hospital or somewhere a remote place of a Assam or a Guwahati, where I can actually look back and tell them a trending is not looking great. So this will actually enable us to work in a multiple centers which sitting in one of these epicenter and probably managing them also. Yes, it will going to. All-round fatigue, if you see, we have lately realized after my 15-20 years that no value in my ICU can be normal. How can a monitor set normal values? If a patient's values are normal, why will be in an ICU? His blood pressure will not be normal, his oxygenation will not be normal, his heart rate will not be normal. If they are all normal, they will be in the ward. If the patient is in ICU, they will be abnormal. My monitor will keep on peeping because it has been set like that. These are all abnormal. And after 10 minutes, after half an hour, my doctor, my nurse will get fatigued and will start ignoring, and they will go and press that button of mute. So how do we solve this? Which are important alarms? There are color codings, there are noises which are the different intensity. So now we are trying to integrate that to see which alarms need to be maintained in such a way that which will give me a critical alert that these patients' alarms are critical. These are, looks like this pattern has been sick patients pattern, so this continues to be the same. So the trend, the pattern can give me something. So these are all evolutions which we're also learning on the process.
Thank you. Shri Dr. Reddy, first of all, I apologize to coming to you last for questions.
No issues.
But I'm going to ask you the most important one of the day, I think, which is really getting to the human factors of care, clinical judgment, cognitive balance, safeguarding patient outcomes. And I want to talk particularly in very high-stakes field like surgery, over-reliance on software of any kind can lead to automation bias, which can erode independent clinical intuition. So as a veteran professor of surgery, your understanding that clinical intuition is forged through observation and experience and reasoning, how do we think about what's necessary for training now to maintain some healthy defensive skepticism towards machine outputs to really safeguard that human in the loop component?
Very good morning, and just bring in greetings from my institute. I have a strategy because I've been seeing the speakers talking about the various aspects of AI. So I don't want to repeat what has already been told. I just thought of putting it in a form like ABCD format. So the first thing which I would like to probably make my students or residents understand is
who is that who is going to be accountable? Is it AI which is accountable, or the treating surgeon who is accountable? And if that statutory warning is in place, I'm sure the students are very cautious. And this is what I just practice routinely. Think that I'm not there when you're operating, then the responsibility falls on the postgraduates. They are more conscious about it. So the first A is basically accountability. The second thing, most of the speakers have been talking about the bias and what we call it as an automation bias. And it's always there that, particularly when we are probably looking at the images and then trying to interpret the findings from the images and then giving a diagnosis, it is not the machine which is at fault. It is basically the person who is trying to sit in front of the machine and trying to interpret the findings and offering you the diagnosis. So particularly when you are trying to probably ensure a patient-centered care, it's very important that you yourself need to probably look at what is the algorithm and then decide actually whether you would like to use that. So the B stands for the bias. The C, the most important thing, and which I always practice, is clinical medicine. And you all know that clinical medicine is a hallmark of a traditional curriculum. I believe I'm a very strong supporter of clinical medicine. So what I would probably, and we have practiced without all this technology when I was a resident, but over years I'm sure that technology has evolved and we started adapting to this technology. But unfortunately, when you look at it, now our residents are more dependent on technology than their clinical acumen. But in my program, I make it sure that first think about what is a possibility and then try to relate it with the technology. So similarly, I would probably expect my residents to focus and understand the disease clinically and then take help of the AI actually, and then probably confirm it, and that is how I would like to go about. The D is, as everyone said, there's a lot of data and there are a lot of recommendations. Whether it is really appropriate for your circumstances and for your patients. And that is something very important when you want to ensure a patient-centered care. So I would expect the residents to validate the data and the recommendations and then probably apply to your patients. So the D stands for the data analysis. E is something very important, empathy and emotional intelligence. And that is a limitation of your AI. And that is where I would like to take advantage of. Suppose if something goes wrong with your treatment, AI is not going to come to your rescue to break the bad news. It is only the doctor-patient relationship which you have established over a period of time can make the patient trust you and believe you when you're trying to break the bad news. So that is something which I would like to probably make my students understand. And of course, F stands for a feedback. I think it's important that there need to be a feedback loop in your residency program for a simple reason, because if the residents are dependent too much on technology and then they just want to ignore the clinical reasoning skills, and you know what consequences we are likely to face. So there need to be a system in place which would like to probably raise a red flag to caution you that this is the time, this is where you need to stop. So finally, I just would like to probably say my inner feelings. As a resident, and I always was very fond of William Osler, and I always used to believe in a saying that there are two distinct kind of doctors, those who practice with the brains and those who practice with the tongues. But it took a lot of time when I got matured and then I became a faculty. Then I realized just brain and tongue doesn't work alone. You need to probably use your brain, tongue, and of course the ear. I believe in ear. So this is where probably you need to develop yourself and competent enough and ensure quality care. But today, I'm sure that I would say that it is not just the brain, the hand, the tongue, and the nose. It is also AI, which you need to include as a part of your program, and only then I'm sure you would be successful. And that is what is my thought. These are my thoughts, and I just would like to thank for this opportunity.
Amazing. Thank you. I think that's really the mnemonic I will borrow as well, along with surgical safety and cyber security as kind of analogies. Thank you for bringing us in for a landing. I think we're very close on time. I've been honored to share the stage with my fellow discussants. I don't know if we have time for a question or two, but perhaps favoring questions from students if available, but yes, would love to hear from the group.
This question is mainly to Dr. Peter. So coming from a general surgery background, being a clinician, I am very happy that AI is helping to improve the workflow of the clinicians and helping the doctors. But at the same time, I'm concerned about the residents that are, not even the residents, the MBBS students, the undergraduate students that are coming out. India is producing a lot of undergraduate students coming from various medical colleges. At the same time, I'm concerned about the big companies who will in future might produce some virtual doctors that will replace the undergraduate students. So they cannot replace each and everything, but they might replace some basic ailments. Say that they might create some models for subscription. So will the doctors be replaced because of this?
Yeah, so first of all, thank you.
And they might also create some randomized control trials to prove that these are as equal to these doctors.
Yeah.
So I'm concerned about that.
I understand the concern, and I think I would maybe reflect a little bit of what was said previously, that I think doctors who use AI will be an advantage to doctors who don't use AI. But I also think, like Dr. Reddy, patients want human interaction, and there is no dearth of patients who sort of require care. So I still think that the goal is not to replace, but to augment clinicians and to elevate what you're capable of doing in practice beyond kind of the current limitations. I also recognize that it is a time of uncertainty, but from that uncertainty, I think also comes new opportunities, especially for people who are learning in the setting of a whole new set of tools.
Thank you.